Hello, I'm Professor Sims, and in this video, I will discuss blood vessels. This is the fourth in a series of 10 lessons held as part of my Anatomy and Physiology 2 online laboratory course. If you're a student currently enrolled in this course, please consult the syllabus and course Moodle site for assignments, quizzes, due dates, and other course information. By the end of this lesson, you will be able to explain the relationship between electrical and mechanical events of the heart, identify structures associated with the electrical conduction of the heart, understand and explain the importance of an ECG, identify ECG tracings, and define specific components, know arterial blood pressure and how to measure it, describe how the auscultation of the heart is related to valve mechanics, be able to take a manual pulse rate and calculate beats per minute, and practice operating a sphygmomanometer and accurately measure blood pressure. Blood vessels are more than just passive tubes. They play dynamic and essential roles in maintaining homeostasis throughout the body. First, their primary function is transport. Blood vessels carry oxygen, nutrients, hormones, and immune cells to body tissues, while also helping remove carbon dioxide and metabolic waste products. They also play a key role in regulating blood pressure and systemic vascular resistance. By changing their diameter, vessels control how easily blood flows through the body, which directly impacts both local and overall circulation. Another important function is the ability to redirect blood flow. For example, during exercise, vessels dilate to deliver more blood to skeletal muscles and reduce flow to digestive organs. This allows the body to prioritize where blood is most needed at any given time. Finally, blood vessels assist in thermoregulation. Through vasodilation, vessels near the skin widen to release heat, while vasoconstriction narrows them to conserve heat when it's cold. Understanding these functions help to explain how vascular health impacts nearly every system in the body, from metabolism to temperature control to blood pressure management. Blood vessels come in several types. Each is specialized to perform unique roles in the circulatory system. Arteries have thick muscular walls that help them to withstand and regulate the high-pressure blood flow directly from the heart. Their strong walls allow them to maintain blood pressure and control blood distribution. Veins have thinner walls and larger lumens compared to the arteries. Because the pressure in veins is much lower, they rely on valves and the action of skeletal muscle contractions to help push blood back toward the heart, preventing backflow. Between these two, the veins and arteries, arterioles. Arterioles are smaller branches of arteries that play a crucial role in controlling blood flow into the capillary beds, effectively regulating blood distribution to tissues. Capillaries are the smallest blood vessels and the main site for exchange of gases, nutrients, and wastes between blood and tissues. And then venules collect blood from the capillaries and merge to form larger veins, continuing the journey of blood back to the heart. Together, all of the vessel types form a continuous, adaptable network essential for efficient circulation. Let's go through the main arteries of the brain and some tips to help you identify them. The internal carotid artery is a large, major vessel entering the brain from the neck. It's one of the primary sources of blood to the brain's anterior circulation. Branching from that, the anterior cerebral artery runs forward and medially to supply the front lobes, while the middle cerebral artery extends laterally into the lateral brain surface, supplying much of the cerebral cortex. The anterior communicating artery forms a small but important connection between the two anterior cerebral arteries, completing part of the circle of Willis. Posteriorly, the basilar artery runs along the brainstem and gives off branches like the superior cerebral artery and anterior inferior cerebral artery. The vertebral arteries merge to form the basilar artery and also give off the posterior inferior cerebral artery. The posterior cerebral artery arises from the basilar artery and supplies the occipital lobes and inferior temporal lobes. Small communicating arteries like the posterior communicating artery connect the posterior and anterior circulations, which also helps form the circle of Willis. And then other notable branches include the ophthalmic artery, which supplies the eye, the anterior carotid artery, which supplies the deep brain structures. And I know these names are very difficult, so some tips for identifying these arteries. Look for large vessels entering the base of the brain. These are typically the internal carotid and vertebral arteries. The circle of Willis is a ring-like arterial structure at the brain's base formed by communicating arteries, and spotting this circle helps you to locate many of the other arteries. Lateral branches running along the sides of the brain are often middle cerebral arteries, and then cerebral arteries arise near the brainstem and supply the cerebellum, which is located posteriorly. The anterior spinal artery runs along the front of the spinal cord, so it's usually visible as a small artery descending from the vertebral arteries. That's this one here, the spinal. The aorta is the largest artery in the body, and it is divided up into 3 main sections. Each section has important branches that supply blood to the body. First, the ascending aorta rises upward from the heart and gives off the right and left coronary arteries, which supply oxygen-rich blood directly to the heart muscle itself. Next is the aortic arch. The aortic arch is this part here. This is a curved portion that gives rise to arteries supplying the head, neck, and upper limbs. These include brachiocephalic artery, which branches further into the right common carotid artery and right subclavian artery, and the left common carotid artery and the left subclavian artery. Finally, the aorta continues downward as the descending aorta, this part here, and this is subdivided into thoracic aorta, which passes through the thoracic cavity, and then the abdominal aorta, which runs below the diaphragm and supplies blood to the organs of the thorax, abdomen, and lower limbs. Again, some helpful tips for identifying these structures. The ascending aorta is directly connected to the heart's left ventricle, and it curves into the aortic arch. The coronary arteries arise just above the aortic valve and wrap around the heart's surface. The brachiocephalic artery is the first major branch off of the aortic arch, so this one here. And on the right side, it quickly splits into the right common carotid and the right subclavian arteries. The left common carotid and left subclavian arteries branch directly from the aortic arch. The descending aorta runs posteriorly along the spine and becomes the thoracic aorta in the chest, and then the abdominal aorta after passing through the diaphragm. This diagram here highlights the major arteries branching from the abdominal aorta, which is, of course, the main artery supplying blood to the abdominal organs. The abdominal aorta is a continuation of the thoracic aorta. It runs down the abdomen, delivering oxygenated blood to many vital organs in the body. One of the first major branches is the celiac trunk, which then divides into 3 important arteries. The left gastric artery, which supplies blood to the stomach. The splenic artery travels toward the spleen and also sends branches to the pancreas and stomach. And the common hepatic artery supplies the liver, gallbladder, and parts of the stomach and pancreas. Next, the superior mesenteric artery branches off to supply most of the small intestine, and then the proximal portion of the large intestine as well. This artery supports digestion and nutrition absorption by delivering blood to the intestines. Lower still is the inferior mesenteric artery. This one provides blood to the distal part of the large intestine and the rectum, supporting the later stages of digestion and waste processing. Tips for identifying these. The celiac trunk is a short, thick branch right near the top of the abdominal aorta and just below the diaphragm. And then the superior mesenteric artery arises just below the celiac trunk and heads down towards the intestines. This figure helps illustrate the major arteries supplying blood to the arm from the shoulder down to the fingers. Starting proximally, the right subclavian artery originates from the aortic arch on the left side, or brachiocephalic artery on the right side, and it travels under the clavicle to become the axillary artery as it enters the armpit region. From the axillary artery, several important branches emerge. You have the humeral circumflex arteries. These wrap around the humerus, supplying blood to the shoulder joint and surrounding muscles. The deep brachial artery runs posterior to the humerus, supplying the triceps and other arm muscles. Continuing down the arm, the axillary artery becomes the brachial artery, which is the main blood vessel of the upper arm. Near the elbow, the brachial artery gives off branches like the ulnar, collateral arteries, which support blood flow around the elbow joint. Then beyond the elbow, the brachial artery splits into the radial and ulnar arteries. The radial artery runs along the lateral or the thumb side of the forearm. The ulnar artery courses medially toward the little finger side. Both arteries contribute to the hand's blood supply through two main arches. The deep palmar arch, mainly formed by the radial artery, and then the superficial palmar arch, primarily supplied by the ulnar artery. From these arches, the digital arteries branch out to supply the fingers, and then one additional important artery, the arterial crural interosseous artery, runs in the forearm's interosseous membrane region, helping supply deep forearm structures. So to identify these arteries, follow the path from the shoulder down to the hand to see how the arteries change names based on location. And note how the radial and ulnar arteries form arches in the palm. These arches are key for collateral blood flow to the hand. Look for smaller branches like the humeral circumflex and deep brachial arteries, which supply specific muscles around the humerus. The inferior mesenteric artery is located lower on the abdominal aorta and runs toward the left side of the abdomen. And recognizing these major branches and their target organs will help you understand how blood flow supports the function in this region. This figure is giving both an anterior and posterior view of the major arteries of the leg, tracing the flow of blood from the pelvis down to the toes. So let's start up here at the top. The common iliac artery branches from the abdominal aorta and quickly divides into the external iliac and internal iliac arteries. The external iliac artery passes under inguinal ligament to become the femoral artery, which is the main supplier of the anterior thigh. Before this transition, the internal iliac artery gives off important branches like the internal pudendal, obturator, and lateral sacral arteries, supplying pelvic organs and muscles. Now moving into the thigh, the deep femoral artery, also known as the profunda femoris, this branches off the femoral and sends off the lateral femoral circumflex artery, which supplies blood to the thigh muscles and hip joint. Then around the knee, the femoral artery becomes the popliteal artery behind the knee and gives rise to the genicular arteries, which supply the knee joint. Finally, and then below the knee, the popliteal artery splits into the anterior tibial artery, which runs down the front of the leg and becomes the dorsalis pedis artery on the top of the foot. The dorsalis pedis continues into the dorsal arch and gives off digital branches. The posterior tibial artery, which travels down the back of the leg, gives rise to the fibular artery laterally. And then near the foot, the posterior tibial artery branches into the medial plantar and lateral plantar arteries, which form the plantar arch on the sole of the foot. Tips for using these kinds of diagrams: again, on the anterior view, focus on the femoral, anterior tibial, and dorsalis pedis arteries, and on the posterior view, trace the popliteal, posterior tibial, and fibular arteries. Remember that arteries typically change names based on anatomical landmarks, and being able to trace the arteries helps you understand how blood reaches every part of the lower limb, including muscles, joints, and skin. And it's important for interpreting things, not just anatomy, but also clinical conditions like peripheral artery disease. This next figure shows the major venous structures of the head and neck. So we've moved on from arteries to veins now. And this is showing how blood drains from the brain, face, and scalp back towards the heart. So let's begin inside the cranial cavity, where venous blood comes from the brain, drains into specialized channels called dural venous sinuses, and then the superior sagittal sinus runs along the top middle of the brain within the falx cerebri. The inferior sagittal sinus runs parallel but deeper along the lower margin of the falx cerebri, and these both feed into the straight right sinus, which merges with the occipital sinus and right transverse sinus at a point called confluence of sinuses. From the transverse sinus, blood drains into the sigmoid sinus, which curves downward and becomes the internal jugular vein after exiting the skull. Additional sinuses, like the petrosal sinus and cavernous sinus, drain the middle cranial area and communicate with facial veins. This is a clinically important connection because infections in the face can spread to the brain through these routes. Outside the skull, the venous drainage from the scalp and superficial face includes the external jugular vein, which drains the outer structures of the head and neck and empties into the subclavian vein, the vertebral brain, which drains blood from the cervical spinal cord and posterior head. The temporal, maxillary, and facial veins also contribute to venous return from the face and scalp, often joining the internal or external jugular veins. And all this venous blood eventually funnels through the right subclavian vein into the axillary vein and ultimately into the superior vena cava, which returns it to the heart. So some tips interpreting this figure, right? Use symmetry to your advantage. Most of the veins have left and right counterparts. Note that sinuses are part of the brain's internal drainage system and don't follow the same rules as typical veins. The internal jugular is the main route of the deep drainage from the brain, while the external jugular handles much of the superficial drainage. Be able to trace these venous pathways because it will help you to explain how the brain clears waste, how infection can spread, and how blood ultimately returns to the heart from the head. This slide focuses on the major veins of the abdomen, showing how blood is drained from the abdominal organs and lower body regions back to the heart. Let's begin with the central structure on this slide, the inferior vena cava. This is the largest vein in the lower body. It collects deoxygenated blood from below the diaphragm and returns it to the right atrium of the heart. It runs alongside the abdominal aorta, but unlike arteries, veins converge into the IVC, the inferior vena cava, from both paired and unpaired abdominal structures. The hepatic veins drain blood from the liver into the IVC. This includes blood filtered from the liver, particularly from the digestive tract. The renal veins carry filtered blood from the kidneys. Notice how both kidneys have direct drainage into the IVC. The hepatic portal vein, while not directly draining into the IVC, plays a critical role because it carries nutrient-rich but oxygen-poor blood from digestive organs to the liver, where it's processed before entering the hepatic veins. You can see that the superior vena cava and its contributors like the subclavian, internal jugular, and brachiocephalic veins at the top, these handle drainage from the upper body, but are included here for context. The azygos and hemiazygos systems are shown running along the vertebral column. These veins are important for draining the thoracic wall and for connecting the superior and inferior vena cava. The anterior thoracic, mediastinal, and esophageal veins also contribute to drainage from the thoracic organs. The gonadal, adrenal, phrenic, and lumbar veins feed into the IVC at various levels, representing venous return from the reproductive organs, adrenal glands, diaphragm, and lower back, respectively. The common iliac, internal iliac, and external iliac veins merge to form the lower end of the IVC and are responsible for venous return from the legs and pelvis. So when you are looking at a diagram like this, make sure you follow the color-coded diagram. Usually blue is for veins and red is for arteries. And go from bottom to top to trace how the blood returns from the body to the heart. Veins in the abdomen don't always mirror arteries exactly, especially with the hepatic portal system, which adds a second capillary bed in the liver before blood reaches the IVC. And the hepatic portal vein is not labeled in all diagrams, so remember its functional role even if it's not directly visible, because it feeds into the liver, not the IVC. Here's a diagram that highlights the major veins of the arm, including both superficial and deep venous pathways that return deoxygenated blood from the hand and arm back to the heart. So let's start at the fingertips and work our way up. Digital veins drain blood from the fingers and lead into the palmar venous arches located in the hand. These arches collect blood and distribute it into both superficial and deep veins of the forearm. In the forearm, we will see 3 primary superficial veins. The cephalic vein runs along the lateral side, the thumb side. The basilic vein runs along the medial side, or the pinky side. The median artebrachial vein travels through the middle of the anterior forearm and often drains into either the basilic or median cubital vein. One of the most important clinical veins, the medial cubital vein, is located in the anterior elbow. It's here. This connects the cephalic and basilic veins, and it's a common site for venipuncture or blood draws. And then in the upper arm, the cephalic continues up the lateral arm and drains into the axillary vein. The basilic runs medially and joins the brachial veins, deep veins that accompany the brachial artery. And then together they form the axillary vein, which receives blood from the subscapular vein and continues as the subclavian vein at the shoulder. So remember that the cephalic and basilic veins are both superficial and they're both visible through the skin, which makes them helpful in clinical settings. The brachial vein is deeper and typically paired with the brachial artery, which you might explore during dissection or in ultrasound studies. Note how many of these veins have symmetry on both arms and how they eventually converge into the subclavian vein, leading into the superior vena cava and back to the heart. Understanding the layout of these veins help you interpret blood flow and also to find reliable access points for IV or blood draws. This figure here shows both anterior and posterior views of the major veins of the leg, highlighting the complex but organized pathways that return blood from the lower extremities back to the heart. Let's start deep in the pelvis and work our way down and then back up. So first you have the common iliac vein. This is formed by merging of the external and internal iliac veins. The internal iliac vein drains pelvic structures and receives tributaries like the gluteal, lateral sacral, internal pudendal, and obturator vein. The external iliac vein continues into the thigh and becomes the femoral vein, one of the main deep veins of the leg. The deep femoral and femoral circumflex veins drain the deeper thigh muscles and join the femoral vein proximally. In the lower leg and foot, the deep veins include arteriotibial, posteriotibial, and fibular veins, which run alongside their corresponding arteries. These veins drain into the popliteal vein behind the knee, which continues as the femoral vein as it ascends the thigh. From the foot, deoxygenated blood begins its return journey via the digital veins, which drain into the dorsal venous arch and plantar venous arch. The medial and lateral plantar veins drain the sole of the foot and join the posteriotibial vein. And then, of course, don't forget the superficial venous system, which is key for clinical procedures and venous return. The great saphenous vein runs along the medial aspect of the leg and thigh. This is the longest vein in the body and a common choice for grafts in coronary bypass surgery. The small saphenous vein runs along the posterior aspect of the calf and drains into the popliteal vein behind the knee. So some more tips for identifying these things. Use the anatomical landmarks, right? The popliteal fossa, the inguinal ligament. These can help you to orient yourself on both the anterior and posterior views. And remember that deep veins typically mirror arteries, while superficial veins are more variable in their location. Now let's take a closer look at the basic structures shared by most blood vessels, especially arteries and veins, so that we can understand these layers and how they're essential to different parts of the body. So let's go layer by layer from the inside out. First, you have the tunica intima. This is the innermost layer, and it lines the lumen, the central blood-filled space inside the vessel. This layer is made up of endothelium, which is a smooth sheet of simple squamous epithelial cells that minimizes friction and keeps blood flowing smoothly. smoothly. The endothelium also plays a role in regulating blood pressure and clotting responses. Next, you have the tunica media. This is the middle layer, and it's made of smooth muscle and elastic fibers. It is the thickest layer in arteries, where it helps withstand and regulate high blood pressure. The smooth muscle allows the vessel to vasoconstrict or vasodilate. Vasoconstrict means to narrow, vasodilate means to widen, and this adjusts blood flow to organs based on the body's needs. Tunica externa, also called the adventitia, is the outermost layer. It's mostly connective tissue, and it provides protection and structural support. In larger vessels, it may contain small blood vessels and nerves that supply the vessel wall itself. The lumen is the open central space where blood actually flows. Its size can vary depending on the vessel type and whether the smooth muscle in the tunica media is contracting. And then valves are an important feature found in many veins, especially in the limbs. These one-way structures prevent blood from flowing backward, which is important in low-pressure areas where gravity works against venous return. Keep in mind that arteries and veins share the same general layers, but the proportions and functions of each layer differ. Arteries have thicker media, while veins have thinner walls, larger lumens, and valves. Recognizing these differences will help you in identifying vessels in dissection or histology. This figure shows a side-by-side comparison of different types of blood vessels, each labeled with the three major layers, the tunica intima, tunica media, and tunica externa, and there are noticeable differences in thickness, composition, and other features. So let's look at we'll start at the arterial side. Elastic arteries, like the aorta, have very thick tunica media that is rich in elastic fibers. This elasticity helps them to stretch and recoil with each heartbeat, maintaining steady blood flow despite pressure changes. Their tunica externa is also well developed for support. Muscular arteries, like the brachial or femoral artery, have a slightly thinner tunica media than elastic arteries, but they're dominated by smooth muscle. And these vessels are important for regulating blood flow to organs by vasoconstriction or vasodilation. Arterioles are much smaller and thinner, and you'll see the same three layers labeled, but they are in reduced proportions. The tunica media is only a few smooth muscle cells thick, which is enough to control blood entry into the capillary beds. Now shifting to the veins, you have venules. Remember, these are the ones that receive blood from capillaries. They have very thin walls, but all of the tunics are present. They're just hard to distinguish histologically, especially the tunica media, which is often just a few muscle cells thick. The medium-sized veins have a wider lumen and thinner walls than arteries of the same diameter. You can clearly see the three layers labeled here. You may also be able to spot valves inside of the lumen that prevent backflow. Large veins, such as the inferior vena cava, the IVC, have a well-developed tunica externa that may contain smooth muscle cells, vasa vasorum, or small blood vessels that supply the vessel wall itself, and nervi vasorum, which are tiny nerves that help regulate muscle tone. Their tunica media is thinner compared to arteries, but still supports low-pressure blood return to the heart. By comparing all of these side by side, you can see how the structure reflects function, right? Arteries need thick walls to handle high pressure. Veins need wider lumens, valves, and support in the tunica externa to move blood back to the heart, often against gravity. This slide helps to show you how what you feel, your pulse, and what you hear, heart sounds, are connected and what's actually happening inside of the heart. So let's walk through the events shown in the diagram. On the x-axis, we see time progressing across the cardiac cycle, and then on the y-axis, we'll see changes in pressure, specifically in the atria, ventricles, and aorta, which directly relate to valve function and blood flow. First, the lub, or the S1 sound, occurs when atrioventricular valves, the AV valves, close. close. This happens at the start of ventricular contraction as pressure in the ventricles rises. So this is what's called the systole. The ventricular contraction is the systole. And then on the diagram, you can see this labeled at the point where ventricular pressure rises above atrial pressure. Next, the dub or S2 sound happens when the semilunar valves, the aortic and pulmonary valves, close. This marks the end of the systole and start of the ventricular relaxation, which is also called diastole. On the chart, this corresponds to when the aortic pressure is greater than ventricular pressure. This forces the aortic valve to close. Each lub-dub sequence reflects one complete heartbeat and creates one pulse wave that travels through the arteries. This is the same wave that you feel at your wrist or your neck when you're checking your pulse. You'll be using this information in the lab to locate pulse points and to listen to heart sounds with a stethoscope, or if you're online, you'll be doing this virtually, obviously. The lub sound is the AV valves closing at the start of systole. Dub is the semilunar valves closing at the end of systole and marks the start of the diastole. Understanding the timing and cause of these sounds and how they align with pressure changes in the heart will help you interpret both physical exams and clinical diagnostics like heart oscillation and ECG readings. Each time the ventricles contract and force blood into the arteries, it creates a pressure wave that you can feel, and which is called a pulse, and you can feel this at certain spots of the body. These are what are known as pulse points. The diagram shows major arteries where pulse is commonly checked. Let's walk through a few of the most accessible ones. So the radial artery is located at the wrist. It's most commonly used for pulse checks. Then you have the carotid artery in the neck. This is ideal during emergency assessments. The brachial artery is often used in infants when taking blood pressure. The femoral, popliteal, posterior tibula, and dorsalis pedis pulses are assessed in the legs and feet, especially when checking for peripheral circulation. To take a pulse, you will use your index and middle fingers, not your thumb, because your thumb has its own pulse. Then you will gently press over the artery and count the beats. You can count for 15 seconds and multiply by 4, or count for the full 60 seconds for more accuracy, especially if the rhythm seems irregular. Pulse rate reflects not just heart activity, but also the efficiency of circulation, and it can vary with exercise, body position, temperature, and even emotional state. So whether you're checking the wrist or the foot, the pulse gives you a real-time snapshot of cardiovascular function. Remember that blood circulation depends not only on the structure of vessels and chambers, but on the timing and strength of heart contractions, which are controlled by its electrical conduction system. Let's briefly walk through the 3 key electrical events in the cardiac cycle. First, polarization is the heart cell's resting state. Inside the cell is more negative than outside of the cell, and the cell is ready to be activated. When the heart needs to contract, depolarization occurs. Positive ions like sodium and calcium flow into the cell, making the inside more positive, and then this triggers contraction of the muscle. This depolarization wave spreads from the SA node through the atria, and then pauses briefly at the AV node and continues down the ventricles. After contraction, the heart must reset. This is repolarization, and that means this is when the ions are pumped back out of the cells to restore the negative resting state. Repolarization allows the heart to relax and prepare for the next beat. These electrical changes, depolarization and repolarization, create small voltage differences that can be detected by skin electrodes. The result is an ECG trace, which we'll examine closely in the next slide. Just remember that what you see on an ECG represents the electrical events, but those changes are what cause the mechanical pumping that you feel as the heartbeat. An ECG records the heart's electrical activity by measuring the combined direction and strength, also known as vector, of all of the depolarization and repolarization waves moving through the cardiac muscle. This figure here is reflecting the overall electrical currents as they travel through the atria and ventricles during each heartbeat. And you'll notice that the key waves and points are labeled here. The the P wave. The P wave represents arterial depolarization. So this is when the arteria contract. The QRS complex, this bit in the middle, corresponds to ventricular depolarization. So this is the main pumping contraction. And then the T wave marks ventricular repolarization as the ventricles recover and relax. By analyzing the shape, the timing, and the size of these waves, clinicians can identify abnormalities that may indicate heart muscle injury, problems in the conduction system, or other types of cardiac issues. Now let's break down the key parts of the ECG waveform and what they represent in the cardiac cycle. The PR interval covers the time from the start of atrial depolarization, the beginning of the P wave, through to the start of ventricular depolarization, which is the beginning of the QRS complex. This reflects the time it takes for the electrical impulse to travel from the atria to the AV node to the ventricles. Then you have the PR segment. This is the flat line between the P wave and the QRS complex. This corresponds to the AV node delay, where the impulse pauses briefly to allow ventricles to fill with blood before contracting. The QRS complex marks ventricular depolarization, triggering the ventricles to contract and pump blood. The ST segment is the flat line following the QRS complex and represents the early phase of ventricular repolarization. This is basically when the ventricles start to recover. And then the T wave shows the ventricular repolarization or recovery, preparing the ventricles for the next heartbeat. And then finally, the QT interval spans from the beginning of ventricular depolarization to the end of ventricular repolarization, indicating the total time the ventricles take to contract and then recover. So understanding what these intervals are and what the segments are helps you to interpret ECGs accurately and recognize normal versus abnormal heart functions. Blood pressure is a key vital sign that reflects how well your heart and blood vessels are working together to circulate blood. Each heartbeat, driven by the heart's electrical signals, generates pressure that pushes blood through your arteries. Systolic pressure is the higher number, and it represents the force of blood against the artery walls during ventricular contraction when the heart is actively pumping. And diastolic pressure is the lower number, measuring the pressure in the arteries when the heart is resting between beats. Monitoring blood pressure is important because abnormal values can indicate potential risks to cardiovascular health, put stress on organs, and suggest problems with circulation. Let's walk through how to measure blood pressure using a sphygmomanometer and stethoscope. First, the cuff is wrapped around the upper arm and inflated enough to temporarily stop blood flow into the brachial artery. Then, as the cuff pressure is slowly released, you listen carefully with a stethoscope for carrot cough sounds. Carrot cough sounds are the sounds of blood beginning to flow again. The first sound you hear marks the systolic pressure when the blood starts moving through the artery during ventricular contraction, and then the point where the sound disappears marks the diastolic pressure when blood flows freely as the heart relaxes. Blood pressure readings are recorded in millimeters of mercury or mmHg, for example, 120 mmHg over 80 mmHg. And then before starting the lab for blood vessels activities, please complete the following preparation tasks. First, read the blood vessels chapter in your book. Then review the introduction and background sections in chapter 4 of the lab manual. And then complete the pre-lab exercises 4.1 through 4.3 and use the answers for those to complete the Lab 4 quiz on Moodle. Next, for the lab exercises, you will work with blood vessel models found in Chapter 4 of your lab manual for 4.1. Focus on figures 4.3 and 4.4. This is where you will identify and label several key arteries and veins. Specifically, you need to label the brachial, radial, ulnar, femoral, popliteal, and plantar arteries, as well as the axillary, basilic, median cubital, femoral, and great saphenous veins. Take your time to observe the models carefully and note the spatial relationships among these vessels. Here you can see a couple of examples of the models highlighting some key arteries in the body which correspond to what you'll observe in your blood vessel models. Starting in the upper limb, the right subclavian artery travels beneath the clavicle. It becomes the axillary artery as it enters the armpit. From there, it continues as the brachial artery, which runs down the upper arm. Then the brachial artery branches into the radial and ulnar artery, supplying blood to the forearm and hand. And then moving over to the abdominal region, the superior mesenteric artery branches off the abdominal aorta to supply much of the small intestine, part of the large intestine. The gonadal arteries, which include the testicular or ovarian arteries, branch from the abdominal aorta to supply the reproductive organs. And then finally, the inferior mesenteric artery supplies the distal portion of the large intestine and the rectum. The femoral artery is the major blood vessel supplying blood to the thigh and lower limb. And then as it travels down, it becomes the popliteal artery behind the knee. And from there, it branches into the anterior tibial artery, which supplies the front of the lower leg, and the posterior tibial artery, which supplies blood to the back of the lower leg and the foot. And then turning to the veins of upper limb. So these are arteries of the leg, these are veins of the arm. The right subclavian vein collects blood from the arm and shoulder and drains into the large veins beneath the heart. And then closer to the arm, the axillary vein runs through the armpit area and continues as the subclavian vein. Two prominent superficial veins you'll identify are the cephalic vein, which runs along the lateral side of the arm, and the basilic vein, which is found on the medial side. And then the median cubital vein, found at the elbow here, connects the cephalic and basilic veins, and this is a common site for venipuncture, as we discussed. Here we have key veins involved in returning blood to the heart and from the lower limb. At the top, we have the superior vena cava. This is a large vein that collects deoxygenated blood from the upper body, including the head, neck, and arms, and it channels into the right atrium of the heart. The right and left pulmonary veins, here and here. These are unique among veins because they carry oxygenated blood from the lungs back to the left atrium of the heart. Then in the lower leg, the femoral vein. This is a deep vein that drains blood from the thigh and leg, and it runs alongside the femoral artery. And then the great saphenous veins. The great saphenous vein, this is the longest superficial vein in the body, and it runs along the medial side of the leg, and it's often used for grafts and bypass surgery due to its length and accessibility. For the next exercise, you'll be working with histology slides from Chapter 4 of your lab manual, specifically Figure 4.5. Your task is to carefully examine and identify several key structures. First, distinguish between a vein and an artery based on their wall thickness, shape, and the size of their lumens. Identify surrounding adipose tissue, which often cushions and insulates blood vessels. Locate nervous tissue nearby, because nerves commonly run alongside these vessels. Pay close attention to the three layers of the blood vessel wall, labeling the tunica intima, tunica media, and tunica externa for both the artery and the veins. Remember, the tunica intima is the innermost layer lined by endothelium. The tunica media is the thick muscular layer controlling vessel diameter, and tunica externa is the outer connective tissue layer that provides support. On this side, you'll see some labeled images that highlight key structures in blood vessel histology, including the arteries, veins, nerves, different layers of arterial wall, and these are at 400 times magnification. So let's break down what you should focus on when identifying these structures under the microscope. First, the mnemonic LIME, L-I-M-E, helps to remember the vessel wall layers, right? So L is for lumen. That's the hollow space where blood flows. It's the starting point for identifying vessels, really. Then intima, tunica intima. This is the innermost layer, composed of thin endothelium, and it provides a smooth lining to reduce friction for blood flow. Then media, tunica media, is the thick middle layer made up of mostly smooth muscle cells. This is the layer that controls diameter. And then externa, tunica externa, right? Lime externa. The tunica externa is the outer connective tissue layer that anchors the vessel to surrounding tissues. And then when comparing arteries to veins, arteries are always going to have a thicker tunica media. It's going to have a lot more smooth muscle, this part here. And this makes not only the arteries walls thicker, but it makes them more round when you're looking at them through cross-section like this. See how this vein is kind of flattened? This is much more round. It's because of that big thick tunica media. The lumen of arteries is generally smaller relative to wall thickness, whereas veins have thinner walls, especially in the tunica media, and their lumens are usually larger and often appear collapsed or flattened, like this one here. Veins may also show valves. The valves will appear as thin flaps projecting into the lumen, preventing blood backflow. Looking at arterial walls at high magnification, you can distinguish the tunica intima by its smooth endothelial lining and the internal elastic lamina, which often appears as wavy. It appears as a wavy dark line. Tunica media contains smooth muscle fibers arranged in circular layers. And then the tunica externa is mostly connective tissue. You may see some collagen and elastic fibers, and it appears less organized and contains fewer nuclei. Some additional clues: large arteries like the aorta will show elastic lamellae between the tunica intima and media, giving the walls a wavy appearance like this. Nerves often run alongside vessels and can be seen as small bundles of fibers with nuclei. So here's a good example of that. Remember to observe vessel shape, because arteries are usually more rounded and uniform in shape, while veins are going to appear irregular or flattened. Next, you will need an internet-connected computer. We're going to do an interactive web activity. You will visit the website at geekymedics.com here, and there you will find a comprehensive article that explains how to interpret an ECG in clinical settings. Carefully read through this entire article, paying close attention to key terms and the step-by-step process used for ECG interpretation. Take detailed notes on important features of the ECG waveforms, such as the P wave, QRS complex, T wave, and intervals, as well as their clinical significance. And then use these notes to deepen your understanding of how electrical activity of the heart corresponds to mechanical function. Finally, complete the associated questions in your lab manual to reinforce your learning and check for comprehension. This activity is designed to help you connect theory with clinical practice by interpreting real ECG data and understanding its diagnostic importance. On this slide, you will see this is an example of ECG tracing, displaying multiple leads used to monitor the heart's electrical activity from different angles. The leads labeled 1, 2, and 3 represent the standard limb leads, capturing electrical signals between the arms and legs, right? 1, 2, and 3. The augmented leads provide additional perspectives by referencing a combination of limb electrodes. So the augmented leads are these AVR, AVL, AVF. These are providing additional perspectives. The precordial or chest leads, these ones here, V1 through V6. These are placed across the chest to record electrical activity over the anterior and lateral walls of the heart. Each lead gives unique information about the heart's conduction and helps pinpoint areas of normal function or potential abnormalities. As you work through the interactive activity, familiarize yourself with these lead names and positions, since interpreting ECG results often involves comparing patterns across multiple leads. Next, you'll do another interactive web simulation where you will practice measuring blood pressure. Once you go to this website here, start by clicking the inflate button to increase pressure in the cuff, just like when taking real blood pressure. Then use the release valve to slowly deflate the cuff while listening carefully through the stethoscope. And then the first Korotkov sound you hear corresponds to the systolic pressure, the pressure when the heart contracts and blood starts to flow. Continue to release pressure until the sounds disappear, and that point marks the diastolic pressure, when the heart is relaxed. Enter these systolic and diastolic values into the answer boxes provided in the simulation. After completing the measurement, be sure to answer the related questions in your lab manual to reinforce your understanding. This hands-on practice will help you grasp the technique, but also the significance of blood pressure measurement. This here is a screenshot that's giving a preview of the simulation for blood pressure. You'll be working with this virtual sphygomanometer. That's the cuff and gauge used to measure blood pressure, along with a stethoscope and a release valve. As you begin the simulation, inflate the cuff fully using the inflate button. Once it's pressurized, use the release valve to slowly reduce pressure. Keep your focus on the gauge and listen closely for changes in sound. When you hear the first Korotkov sound, that's your systolic pressure. Enter that value into the first box here. And then when the sound disappears, that's your diastolic pressure. Put that here. Once you've recorded the pressures, continue to the questions in your lab manual to apply what you've observed. Thank you guys for watching. Don't forget to do the reading, check the description for more videos related to these topics, and leave your questions for me in the comments below.